I'm Dr. Ronald from Queen Mary Hospital, and today I'm going to share with you about this new disease entity called INI1 deficient sinonasal carcinoma. And we did a little bit of research on the in our population in our cluster. So actually in the sinonasal tract, there's various cell types ranging from epithelial cells to mesenchymal, neuroectodermal, etc. And in the pathology of the sinusal malignancy in descending order, we can find there's carcinoma, sarcoma, lymphoma, and thereafter. And it represents a very extensive list of malignant tumor in this region. So this is extracted from the WHO classification of the head neck tumor in the chapter of the nasal cavity, paranasal sinus, and skull base, and you can see a long list of different pathological classification of the malignant tumor. And today we're actually focusing on one of a well-known classification, which is the sinonasal undifferentiated carcinoma, which was being defined as a highly aggressive carcinoma which lacks squamous or glandular features and not otherwise classifiable. And it accounts for 3 to 5% of all sinonasal carcinoma with a variable range of clinical behavior with a different rates of recurrence and mortality. And people has been suggesting that this sinonasal undifferentiated carcinoma or SNUC is actually representing a heterogeneous group of tumors with distinct biological behavior and aggressiveness. And so far, there's with the emerging use of different immunohistochemical staining and also genetic testing, has been found to be possible subtypes of this SNUC tumor, including HPV-related carcinoma, nut carcinoma, and this disease entity that I'm going to share with you today, the INI1 deficient sinonasal carcinoma. So INI1 stands for integrase inactivator 1, or it can also be represented by another very complicated name called SMARCB1, which is actually a kind of epigenetic, is a tumor suppressor gene that encoded in the chromosome 22, which serves the epigenetic regulation and cell cycle progression regulator of the cell proliferation. So it involves in various signaling cascade and associated with the activation and repression of gene transcription, and eventually will downregulate with the cell proliferation. Therefore, with the deficiency of this protein, it will accelerate the cell proliferation and possible the mechanism of the tumorigenesis. So this INI1 deficient tumor has been already recognized in a group of other tumors which share the similar genetic and histochemical behavior, and also with some similar histology finding under the microscope. Namely, in the kidney, there may be a possible of malignant rhabdoid tumor. In a pediatric population in the brain and the spinal cord, the finding of atypical teratoid rhabdoid tumor, or in short form ATRT, are some examples of this INI1 deficient tumor. And under the microscope, we will see that there's some tumor cells that are organized in a nest and sheet and cord-like appearances without specific differentiation. In particular, pathologists may also find this classical rhabdoid cells, which is characterized with a large cell with abundant cytoplasm with perineural spherical inclusions with vesicular nuclei. And with the use of immunohistochemical staining of INI, it can show there's a complete or partial loss of INI1 protein staining on these tumor cells. With the use of fluorescent in situ hybridization, it may also suggest that the gene expression of this gene could be having a homozygous or heterozygous gene loss. And to extrapolate this INI1 deficient tumor into the sinonasal tract, it was been first described by Professor Agaimy in the United States in 2014, which he reported 3 cases of this sinonasal basaloid squamous cell carcinoma that was initially thought, which shows the common features of loss of INI1 staining on immunohistochemical examination. And so far, there's around 80 cases that has been reported in the literature, with the largest case series of 39 cases, again, published by Professor Agaimy. And he defined this entity is characterized by the loss of INI1 staining, and on the microscopic examination, it resembles the histology of other INI1 deficient tumor in other organs, which I have been mentioning. So it has been recognized, and it was usually being misdiagnosed or being recognized by the pathologist as a sinonasal undifferentiated carcinoma in the past. And so far in the literature, it has been described as a tumor with an aggressive clinical course with a mortality of 54% across a median follow-up period of 16 months. And it has been described in the WHO classification that as an emerging disease entity that we have to be considered in the further study, which more literature review has been is required. So in my study, it is to evaluate the local data of this new disease entity and to report on the clinical demographics. And it is a single center retrospective case series. And we retrieved the pathology specimen in our cluster for the past 70 years, including those with primary sinonasal malignancy with exclusion of those obvious alternatives. And we perform restaining on this specimen with the use of INI1 immunohistochemical staining. The positive cases will be represented with the loss of this INI1 staining. And so far, we found there's 9 patients across the whole 17 years of experience, and there's a compromise of 6 male and 3 females. And the age of presentation ranges from 31 to 64 years old with a median of 43. All of these patients present to us with some epistaxis, and also other symptoms will include nasal obstruction, eye symptoms, and also facial pain. Out of the 9 patients, 6 patients have the tumor over the ethmoid sinus, and 3 is localized, is originated from the maxillary sinus. And of the 6 tumors with over the ethmoid sinus, 4 of them shows extension to the frontal sinus, 2 show extension to the sphenoid sinus, and a high rate of these patients shows orbital invasion up to 2/3 of them, and also a high rate of intracranial extension as shown in this MRI scan, which shows the orbital invasion, and this also shows both the orbital and also the intracranial extension. So all tumors present to us with a locally advanced stage with at least T3, and actually most patients present to us with T4 disease. None of them having nodal disease and none of them having distant metastases. So on review on the initial histology reported by the pathologist, apart from the 3 that has been correctly diagnosed with the more advanced, more usual use of the INI staining by our pathologists in the past few years, actually 4 of them was initially wrongly reported as a sinonasal undifferentiated carcinoma. 1 was reported as a moderately differentiated non-keratinizing squamous cell carcinoma, and 1 was reported as a high-grade non-intestinal type of adenocarcinoma. On retrospective review on the histological description, actually they share some resemblance of this INI1 deficient sinonasal tumor with the features of basaloid cell patterns, prominent nucleoli, and actually some 1 patient's specimen already described the presence of the rhabdoid cell. And all patients received curative treatment, and 5 out of 9 of them received new adjuvant chemotherapy, which shown in the MRI scan here, which show a significant response to the new adjuvant chemotherapy with tumor shrinkage. And afterwards, for the definitive treatment, 2 of them received radical chemoirradiation, and the other 7 of them received surgical excision, either in the form of craniofacial resection as shown here, or cranial-nasal resection with endoscopic mean, radical maxillectomy, or with the use of a total endoscopic resection by a medial maxillectomy. And all patients received postoperative adjuvant treatment. For treatment outcome, they had a complete response in 8 patients out of 9, and the other one was noted to have residual disease after the radical chemo irradiation. Therefore, a salvage cranial nasal resection was performed. These are the Kaplan-Meier curve plotting of the overall survival and the disease-free survival. Across the follow-up period of a median of 44 months, the overall survival was noted to have a median of 30 months, and disease-free survival was 10 months. And on the outcome upon the latest follow-up, 3 out of 9 patients was noted to have recurrence, 2 was having a local recurrence, and 1 was having a distant bone metastasis. The median time to recurrence was noted to be around 14 months. And apart from that, 3 mortalities has been recorded out of the 9 patients with a median period of 33 months, and 2 of them are actually disease-related. For the other 6 patients, 5 are still alive without the disease, and 1 is still with a persistent disease and currently on the palliative chemotherapy. And this table summarizes all 9 patients that has been retrieved and recorded in this study. So this is the is found to have been the first and largest case series of this INI1 deficient sinonasal carcinoma in the Chinese population. And we have been describing the clinical course of this tumor, which have a median overall survival of 30 months and a median disease-free survival of 10 months. We suggest that these patients would require to have a more aggressive treatment with more use of neoadjuvant chemotherapy. And so far, the survival outcome as compared to the other SNUG cohort is more or less the same. And we are trying to compare our data to other case series, which again shows relatively similar clinical pathological outcome with similar high rate of locally advanced presentation, predominance of the ethmoid sinus, and also the high rates of mortality, and also the recurrence. And this is another systematic review which has been published last year. Again, it shows a similar description on the observation that's from the age of presentation, the overall survival, disease-free survival, and also the mortality. Okay. And actually, there's another article that suggests that this disease entity with INI deficient tumor is actually having a relatively poor prognosis compared to the sinonasal undifferentiated carcinoma on their study as well. So the limitation of my study is that it is a retrospective review and with a small sample size and also a relatively short follow-up period. And so far, there's no well-standardized treatment protocol across the world that suggests how we are going to treat this INI1 deficient sinonasal tumor. So therefore, would be required to have more prospective data on the histological description and also the clinical behavior to for us to better understand this disease entity. So for the further insights, we may have to have a larger sample and a longer follow period to complete the study. And in conclusion, it has been hopefully we will be recognizing this INI1 deficient sinonasal carcinoma as a new emergent novel disease entity and with a wider use of an immunohistochemical staining of the INI protein to recognize this disease entity. So hopefully I'm able to convince you that this is a locally advanced tumor with an aggressive clinical course and warrants aggressive treatment. So for the further clinical implication, hopefully with recognize of this disease entity, we can make a diagnosis more precise and provide a better prognostication for tumor for the patient, for better counseling and further treatment protocol. And actually some potential target therapy is on the way of clinical trial, in particular those target therapy which target on various checkpoints over the cell cycle. So hopefully on by the oncologist side, we'll be having a more multimodality treatment that will be useful to make this aggressive tumor more treatable. Okay, and thank you. And before I end my talk, I would just like to thank my supervisor, Dr. Raymond Zhang, for his help on my study.